Uh, Welcome all my dear colleagues in the first Mega Online webinar meeting in the year 2023. Happy New Year for all of you. Today is a very distinctive day because our guest speaker is a well-known international figure in the field of anesthesia and technology in medicine. Our guest speaker is Professor John Doyle. Also, it is very distinctive day because the subject Professor Doyle will talk about is very important for all of us. Whoever you are, senior or junior anesthetist, working in a high or low income country or in a big institute or in the periphery, the subject of today is very relevant and important for you. The subject today is about safety in anesthesia. Regarding standards of safety in anesthesia, we will never find anyone better than Professor Doyle to listen and learn from him about this subject. Professor Doyle is a staff anesthesiologist in Cleveland Clinic, as well as Professor of Anaesthesiology at Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. Professor Doyle received his MD degree in 1982 and PhD degree in Biomedical Engineering in 1986, both from the University of Toronto. He received his Canadian board certification in anesthesia in 1986 and his American certification in anesthesia in 1989. Professor Doyle has a long-standing interest in ENT anesthesia and difficult airway management, as well as an interest in the use of technology in medicine. Dr. Doyle, the floor is yours.
Thank you very much for the kind invitation and the opportunity to speak on a topic that interests me greatly. The topic is the human factor in patient safety. The question is anesthesia finally safe? This is a review and update focusing on human error. Our objectives are to learn more about the nature of human error, to understand the science and root causes of human error based on Reason's Swiss cheese model that we'll have a chance to take a look at later on. Understand the limitations of punishment as a means to responding to human error. And we want to apply these concepts to the field of anesthesiology, clinical medicine, especially with respect to drug errors, planning errors, and workflow errors. We'd also like to review human error in the realm of clinical airway management and look at efforts to reduce these kinds of errors. I have no conflicts of interest regarding this topic. And for those who are interested in a copy of these slides, simply send me an email to djdoyle@hotmail.com and I'd be glad to send you a copy of these slides. Here is a list of the 3 leading causes of death in the United States. Heart disease, number 1, cancer, number 2, medical errors, what a surprise, number 3, according to this report. You can see heart disease, 600,000 plus per year. Cancer, almost 600,000 a year. And medical error, 251,000 per year. So you can see this is big. It is above respiratory disease, accidents, strokes, Alzheimer's disease, and so on. So medical errors are the 3rd leading cause of death in the United States. And we expect that a similar situation exists around the world. Now, I'd like to summarize everything I want to say in one slide and then provide more details later on as I elaborate through this. Human error in medicine can be a failure of the diagnostic process, a treatment failure, a failure to provide prophylactic treatment, and even other things. For example, in the diagnostic process, you may fail to employ indicated tests, or you may misread laboratory tests, or act on the results of monitoring or testing. In treatment, there can be a technical error in performance or preparation of the treatment, for example, the wrong dosage, delayed treatment, which we'll have a chance to talk about in a minute, or inappropriate care, the wrong treatment for a particular patient. Preventive can involve inadequate monitoring or inadequate follow-up to treatment. And then other things might involve a failure to communicate, very important when you're passing on information from one shift to the other. Equipment failure, and then some that are specific to the operating room and ICU. So all of human error falls into these categories. Let's take a look at some of the most common preventable medical errors. Misdiagnosis. The wrong diagnosis can prove catastrophic to a patient in serious need of medical intervention. The wrong treatment can leave a condition rapidly worsening into increasingly severe symptoms, and some treatments can be harmful if they aren't being performed. Delayed diagnosis, a refusal to believe there's an underlying medical condition that can be just dangerous as misdiagnosis. And studies have shown in the United States that women and some minorities experience difficulty in their pain and clinical symptoms being taken seriously by medical practitioners. This can lead to extended periods of suffering and worsening of the condition. Medication errors, which we'll put a lot of emphasis on. A common medical error is when the patient gets the wrong medication. On the top, you can see milrinone and neostigmine look very similarly packaged. In the middle, we have ciprofloxacin and clarithromycin look very similar, even 500 milligrams each. And even the most subtle here, you can see we have all of these ampules for ephedrine. But if you look, the one second from the right is actually heparin, but it looks identical, including the little red dot. Red stripe and the blue dot. So these are how errors can happen. Faulty medical devices can be a problem as well. Manufacturers offer equipment and we trust that they work, but they can fail from time to time, especially on in critical situations, such as a cardiac arrest. An example would be a defibrillator that does not work at the time of a cardiac arrest. Infections are another common problem that we deal with. Medical providers are expected to operate under protocols that limit the risk, from sterile tools and surgery to frequent cleaning and sanitation, but some infections are resilient, and MRSA takes constant vigilance as it's resistant to many antibiotics. It makes it both dangerous and hard to treat. So that can be a problem. We also have retained surgical equipment as a problem. Practitioners can use a variety of tools to work in the body. Here's a retained surgical sponge that was left in after the surgery and then was only apparent after the patient complained of pain and an x-ray was taken to see what was going on. Clamps, swabs, absorbent material have been missed, leading to increased risk of infection as well as pain. So there are protocols to deal with this, particularly with respect to counting. And finally, we have improper medical device placement. Medical devices need to be safe, functional, but also appropriately positioned. In a malposition, for example, of a coronary stent or a nasogastric tube or a feeding tube, all can result in problems. For example, there's been stories of nasogastric tubes inserted and they ended up in the lung rather than in the stomach, and not recognized. The patient was fed and the feeding material went into the lungs. Now, there's a number of medical human error stories that I'd like to bring to your attention. Some of these I know of personally through my colleagues, and some are from the literature. Here is one where 30 milligrams or 3 mLs instead of 3 milligrams of rocuronium was given as a defasciculating dose to an awake patient. The idea is that defasciculation is sometimes done prior to the use of succinylcholine, and they gave 30 milligrams instead of 3. When they recognized it, they immediately put the patient to sleep with propofol. But you can recognize that this can be a serious problem. We don't do defasciculation in the past now like we used to in the past. It used to be we'd use 3 milligrams of curare, but those days are long since past in most settings. In our hospital years ago, 3 mLs or 300 units of insulin was given to treat hyperglycemia instead of 3 units. The error was instantly recognized and the patient did well because they serially measured blood glucose levels with a glucometer and then serially gave increments of D5W or D50, dextrose 50%, in order to make sure that the blood sugar did not drop. And that patient did well. But that's not universally the case. Here in the literature, one patient died because 20 units of insulin was abbreviated as 20U, but the U was mistaken for a 0. And as a result, the dose of 200 units of insulin was accidentally injected. The patient got severe hypoglycemia and died. So you can recognize that insulin, given its enormous strength of 100 units per ml, is potentially problematic. Here is a story of succinylcholine being given instead of ephedrine for hypotension in a laboring patient. It's published in 2004 in the Canadian Journal of Anesthesia. They instantly recognized the apnea and loss of consciousness, and they called the code blue. Mask ventilation was performed until spontaneous breathing resumed, and there were no untoward sequelae. Here is another story. On the left, you can see heparin. On the right, you can see hetastarch. They wanted to give 6% hetastarch to a patient who was hypovolemic as a result of massive bleeding, but in fact, they gave heparin instead, 25,000 units of heparin in this bag, and so the bleeding got worse, not better. So this was hetastarch instead of, this was intended to be hetastarch, but they gave heparin solution instead, heparin in 5% glucose. Another story, a fatal outcome after inadvertent administration of epinephrine intended for topical use. So in this story, a day surgery ENT procedure, the surgeon requested local anesthetic for injection, which is lidocaine 1% with epinephrine 1 in 100,000, was handed a pre-drawn syringe. And the surgeon immediately injected the medication to the surgical site, and afterwards the patient experienced a cardiac arrhythmia, cardiac arrest, and despite resuscitation, the patient followed. What was drawn up was not lidocaine 1% with epinephrine 1 in 100,000, but was this 30 mLs in this container of 1 in 1,000 epinephrine. It's intended for topical use, and this was the drug that was drawn up instead. And here is a particularly sad story of vincristine, commonly used in cancer therapy, being given inadvertently intrathecally. And in fact, it's a whole series of cases. Here in 1998, intrathecal vincristine was given, and they analyzed the reasons for this error and recommendations for improvement when a 7-year-old woman, a girl with recurrent acute lymphoblastic leukemia was inadvertently injected intrathecally with 1.5 milligrams of vincristine. And here is another report in 2001. They didn't learn from the first report. 2 fatal cases, one in a 5-year-old girl with leukemia, and another in a 57-year-old man with lymphoma. And then, as if that isn't enough, in 2002, here they had a fatal myeloencephalopathic state despite cerebral spinal perfusion when intrathecal vincristine was given before. The idea here is that if you recognize that this happened before, you can flush out the drug from the cerebral spinal fluid by cerebral spinal fluid perfusion. But this did not work in this 12-year-old girl who died after 83 days. And then another case report of intrathecal vincristine in 2007 in a 32-year-old man. And here they did cerebrospinal aspiration, external ventricular drains in place. And it turns out that this patient survived. In 2009, 3 fatal cases were reported, and they reported a review of the literature as well. And in 2010, there was a commentary that came dealing with the problem of even more intrathecal vincristine. You would have thought by now people would know that this is a problem. And here, 2011, inadvertent intrathecal vincristine administration report of a fatal case despite cerebrospinal fluid lavage. 2 more cases in 2016. And so many cases going on. How do people not know about this? And in fact, one question is, should you be punished for this in a criminal manner? Here, a doctor was sentenced for manslaughter of a leukemia patient because of vincristine being given intrathecally. Again, that same error. And so the question is, should you go to jail for this? And this gentleman ended up this anesthesiologist or oncologist was charged with manslaughter by the public prosecutor. He eventually pleaded guilty and sentenced to 8 months in prison. All of these are harmful to the patient, many who dies, but it's worthwhile pointing out that there's a second victim as well. A healthcare provider involved in an unanticipated adverse patient event, medical error, or a patient-related injury who becomes victimized himself in the sense that the provider is traumatized by the event. Frequently, second victims feel personally responsible for the unexpected patient outcomes and may feel as if they failed their patient, feel doubts about their clinical skills and knowledge base. So there is, in fact, the concept of the second victim, the participant who caused the harm in the first place. Well, let's take a look at some sources of medical errors, and I have some examples. Here is one of the earlier Palm Pilot devices. This was basically a little computer you could carry around. It's now 15, 20 years old, and it's been replaced by smartphones, but it wasn't long ago that this was very popular. And some of the textbooks, like the Handbook of Clinical Anesthesia, was available as an app that you could get on a PDA. So here is I bought this app, and the Book of Clinical Anesthesia was there. And when I looked up epinephrine, it said, if you want to treat hypotension, use 2 to 8 milligrams. And if you want to treat cardiac arrest, 0.3 to 0.5 micrograms. And for continuous infusion, 0.015 micrograms per kilogram per minute. And I'm thinking, that's not what I remember. So how many errors can you see? Well, number one, 2 to 8 milligrams is not the dose to treat hypotension. 0.3 to 0.5 micrograms is not the dose to treat cardiac arrest. And a continuous infusion, well, it's not 4 milligrams per ml when you put a milligram in 250 mLs. So I wrote to the company, and I was surprised that while they did fix the problem, they were not particularly grateful to me. They did not give me, for example, any free products that I expected as a result of this. They were embarrassed by their error, and I hope nobody was injured as a result of this version of the textbook. Here's another example. Can you tell what this prescription is? What does it say? Well, it turns out it says morphine 10 milligrams IM. Who would have thought? Now, the International Society for Medical Safety recommends that we have a variety of abbreviations, symbols, and dose designations that are not used. So, for example, do not use the abbreviation U, which someone, as I mentioned, saw as a 0. Write it out unit. And then drugs like OD for every day, we should write out daily. And microgram, we should write MCG rather than using the Greek symbol. So these are the Institute for Safe Medical Practice recommendations. There are others that are from the American Association for Family Practice. Instead of writing a trailing 0 like X.0, the decimal point is mixed. Just write X milligrams. And always provide a leading 0 if you're writing 0.5 milligrams, for example. So these are some of the suggestions for abbreviations. Example 3. This is a study identifying a spike in fatal medical errors when new residents arrive. So new residents arrive every July in the United States, Canada, and many other places. And the question is there a spike in fatal medication errors known as the July effect or the new resident effect when we get new residents coming in from other places? Well, the study suggested 3 things. Fatal medication errors spiked in July and in no other month, and this is when the new residents come. The July spike appeared only in counties containing teaching hospitals and weren't present in regular hospitals that did not have a teaching program. And in these counties, July mortality from medication errors was 10% above what was expected. So this suggests that we need to be very careful about what we do with our residents in their first month of a new hospital. So are there remedies available for all of these problems? Indeed, there are many. For example, there are educational posters emphasizing patient safety goals, such as identifying patients correctly. We'll have a chance to talk about that. Improving effective communication, improve the safety of high alert medications, ensure correct site, correct procedure, correct patient surgery. And we have timeouts for that, for example. Reduce the risk of healthcare associated infections and reduce the risk of patient falls. There are a number of high-risk medications, and there's posters that are available for that. Anti-infectives, potassium in particular is dangerous. Insulin can be dangerous, as you saw already. Opioids and narcotics, other sedatives, that can be a problem with oversedation. Chemotherapeutic agents, we have already mentioned with Christine. And heparin, which we've already made reference to when a bag of heparin was given instead of a bag of hetastarch. Checklists are becoming increasingly popular. Here is the surgical safety checklist from the World Health Organization, and it has things carried out before the introduction of anesthesia, things carried out before skin incision, and things carried out before the patient leaves the operating room. And if you go to the World Health Organization website, you can download these or simply Google it, and you can get these for printout in your hospital. For maternity cases, the World Health Organization has things to do for maternity cases, for sign in, for timeout, and for sign out. And so those of you who have busy maternity practices can use this. This is from the Royal College of Obstetricians and Gynecologists. Here is a surgical safety checklist from Australia and New Zealand. Again, sign in, timeout, and sign out. Here is a safety checklist for office-based anesthesia for the Institute for Safety in Office-Based Surgery. Introduction, setting, operation, before discharge, and satisfaction. So this has more stages, and this can be useful in setting up programs for office-based surgery. In the emergency departments, which frequently do intubations, but it's not as much as carried out in the operating room, they offer 4 stages for a pre-intubation checklist: prepare the patient, prepare the equipment, prepare the team, and prepare for possible difficulties. We'll have a chance to talk about more about clinical airway management in a little while, but you can see there's a variety of checklists like this. And in this study carried out in 2012, they looked at the effect of the World Health Organization's safety checklist on complication rate and communication. They write, the checklist should be understood not merely as a list of items to be checked off, but as an instrument for the improvement of communication, teamwork, safety culture in the operating room, and it should be implemented accordingly. The regret is that some people go through the motions without taking the whole business seriously. One thing that we recommend for everybody is the timeout before the incision is made or before intubation is done, etc. Is this the right patient? Do we have the right location? Are we doing the right procedure? So these are posters that are available and can be put up in your operating rooms and offices to help out. Another thing that can be useful are armbands. For example, this patient has an armband that says fall risk. They might, for example, have hip surgery and are at risk of falling out of bed if not properly secured. In fact, one of the concerns that some people have is that there can be a variety of bracelets. Here they have an allergy alert, latex allergy, a fall risk, and they have do not resuscitate in the purple, as well as the patient identifier. So that can be a problem, some people think, and other people say, no, that just reminds you that you have to be vigilant with this patient. Some places are using barcode scanners, and you can see here you have a barcode so that you can know that you've got the right patient when you are, for example, giving a patient a drug or when you're admitting them to the operating room. Sometimes the barcodes are associated with these risk factors like fall risk, latex sensitivity, allergy, and so on. So these can be added together. In some cases, they offer a picture of the patient And that way you can make sure that the armband is actually on the right individual. And they also have these QR codes that can be scanned with the scanner. So there's a variety of ways of using armbands for safety. Now there's more themes I'd like to bring up. Bad design as a contributor to human error, complexity as a contributor, and software as a contributor to human error. So to err is human. It's been repeatedly said over thousands of years that humans make errors. Here is one from Plutarch, 1000 AD. To err is human in Latin. In 1635, Shirley, the Lady of Pleasure, writes, "I presume you're mortal and may err." Pope, Essay on Criticism, "To err is human, to forgive divine." More recently, one of the experts on human error writes, "To err is human, to forgive is against company policy." And this raises the issue of what do you do about human errors? If you punish people, that's not necessarily as helpful as coming up with approaches to remedy the root cause. And we'll have a chance to talk about some of the root cause issues as well. But simply punishing them is not a good way to go. All of these state that human errors will be made by people despite their determination to avoid them, yet people are consistently held accountable for their errors when they lead to accidents with inverse outcomes. Is this proper? Now, Sanders argues that this is not, in the same way that in law, no one is accountable for acts of God in North American and European law. Now, this has resulted in a number of people interested in looking at human factors in preventable human errors, anesthesia mishaps. And as early as 1978, Jeffrey Cooper from Massachusetts General Hospital took an interest in this, and he used a modified critical incident analysis technique for retrospective examination of the characteristics of human error. And they found that 82% of the incidents involved human error, with breathing circuit disconnections, inadvertent changes to gas flow, and drug syringe errors being the most frequent. Equipment problems, overt equipment problems constitute only 14% of the total number of preventable incidents, but equipment design was indictable in many categories of human error. And I'll give you an example of some of this in a little while. Here's just a little cartoon. This is the Dilbert cartoon. "It seems we had a mix-up with your test results," the doctor says, and Dilbert says, "Then I'm not dying." The doctor says, "We doctors are amazingly smart, but occasionally we make a little error." And Dilbert says, "Yes, I understand." The doctor says, "By the way, your pap smear was normal." So clearly he's got information from the wrong patient. How do these errors occur? Well, James T. Reason hypothesized in 1990 that accidents can be traced to one or more 4 levels of failure: organizational influences, unsafe supervision, preconditions for unsafe acts, and the unsafe acts themselves. And the first 3 are called latent failures, and the latter an active failure. To protect yourself against failure, organizations put up a system of defenses or barriers, which he modeled as slices of Swiss cheese. So that an error can result in injury to the patient when these hazards line up. Some holes are due to active failures, others are due to latent failures, but in the end, when all of these line up, you have a problem that has to be dealt with. And this concept repeatedly shows up in the literature. On the upper left, adverse drug reactions as a result of prescribers' incomplete knowledge, as in the vincristine story, computer screening, pharmacist knowledge, patient risk factors, pharmacogenetics, drug administration, patient education, and monitoring. In the case on the upper right, adult respiratory distress syndrome, there can be problems with supervision, inadequate training, inadequate ventilation, inadequate patient monitoring, results in the patient developing adult respiratory stress syndrome. And on the bottom here, a patient can anesthetize for unnecessary surgery with a problem of communication. They have the wrong patient, key policies and procedures being inadequate, team failures, and the surgeon fails to examine, for example, the correct ankle in the case of ankle surgery. So these are all examples from the literature. And it's helpful to look at what kind of human error categories occur. Swain and Gutman suggested that there are 4 categories. Error of omission, like typographical errors, errors of commission, hitting your thumb with a hammer, for example, extraneous acts, reading the wrong report, sequential errors, lighting a fire before opening the damper in a fireplace, and a timing error, running a red light. All of these can be applicable to anesthesia, and we're going to have a chance to take a look at them in a little while. Let's focus on clinical airway management as an example. Historically, this is very interesting that in 1928, Goodell and Waters, pioneers in anesthesia, did the dunked dog experiment on Goodell's family dog. His name was Airway. In the experiment, the dog was sedated and intubated using Goodell's cuffed airway. This was not an endotracheal tube, but a cuffed airway comparable in many ways to our own supraglottic airways that we use today. To show how well the cuffed airway worked, the dog was dunked underwater for an hour and maintained under anesthesia. Since that time, we've got a lot of improvements in the way anesthesia airway management is conducted, from the Miller blades about 32 or so years after the Goodell's experiment, the McIntosh and Miller blades in the early 40s, flexible fiber optic bronchoscopy in the mid 70s, and then McCoy blade, Billard, WooScope, the GlideScope, McGrath, and CMAC, all new technologies that have made laryngoscopy more straightforward. And video laryngoscopy in particular has blossomed with a variety of technologies available. And for many people, video laryngoscopy is their go-to technique for all intubations. But there errors can occur in airway management. Diagnostic errors such as failure to recognize esophageal intubation, treatment errors, delayed reintubation in the post-anesthetic care unit in a patient who develops respiratory failure, preventive, inadequate monitoring of respiration, inadequate follow-up of patient after extubation, and others, failure to communicate about a difficult airway by not writing a note in the chart and letting the patient know. Some airway errors can also include incorrect technique, using a laryngeal mask airway, for example, where an endotracheal tube is needed in a patient with small bowel obstruction, esophageal intubation not recognized, or going through the wrong route, going orally when nasal is more appropriate for jaw surgery, intubation with a correct tube, using a ray tube instead of a reinforced endotracheal tube, endobronchial intubation where only one side is ventilated, the wrong cuff pressure where you have damage to the tracheal mucosa, and incorrect precautions against aspiration, for example, not doing a rapid sequence induction where appropriate. So what are the causes of human error in airway management? It can be poor planning, poor arrangement of the workspace, no testing of equipment prior to the procedure, like your laryngoscope, a lack of knowledge of the importance of certain things, like how to carry out a rapid sequence induction, no knowledge of airway algorithms, such as the difficult airway algorithms from the Difficult Airway Society and the American Society of Anesthesiologists, poor judgment, thinking the airway would be straightforward, but it's not, limited experience, hubris or pride, denial that there's a problem, particularly with esophageal intubations. You may deny that there's a problem because you thought you saw it through the cords, failure to arrange for help before trouble starts, and failure to call for help when trouble starts. So these are all some problems of human error in clinical airway management. Now that fiber optic intubation is getting more common, what kind of failed techniques, failed issues can occur? A lack of expertise is the most common, simply not having done it enough. Secretion and blood get in the way. Remember, you need two suctions, one the Yankauer for the patient, and then one for suction for the fiber optic bronchoscope itself. Fogging the lenses can occur. Poor topical anesthesia may make the patient uncooperative. The anatomy may be distorted. The fibroscope may be malfunction, and you may even pass the fibroscope through the Murphy's eye of your endotracheal tube. So remember Swain and Gutman's human error categories? What are some examples in their category system? Well, we have error of omission, failure to inflate the endotracheal tube, error of omission, failure to inflate the endotracheal tube, an error of commission, breaking a tooth while intubating, an extraneous act, drawing out drugs not needed, a sequential error, giving drugs before checking your equipment, and a timing error, for example, intubating too early when relaxation is suboptimal. So let's take a look at the implications of all of this for anesthesiology, focusing on workspace organization, drug and syringe labeling, drug and vial and ampule checking, problem of production pressure, and the problem of sleep deprivation. So you can see anesthesia, workspace organization can be very important. We want to lay out all of our equipment properly. And you can see on the bottom right, sometimes you may be in very confined quarters, such as this case of aeromedical evacuation. Well, let's start with drug and syringe labeling. There's a variety of recommended standards that the International Standards Organization has offered, and you can get this information as shown here, how you may want to label syringes and drugs. One of the things that you want to do is take a look at some of the recommendations to the risk of drug error in anesthesia. And here on the right, this article 2004 suggests a variety of things, from the lighting of the operating room so that you can see well, that you have drug storage arrangements that are consistent so that the drug arrangements in one room are the same as another, so that it's easy to find something. Ampules will be read and reread before the drugs are drawn up. Errors are unlikely to be detected once the syringe is prepared. They recommend the International Color Coding Syringe Labeling System. Using pre-filled syringes for emergency drugs are recommended if the pharmacy can provide them. Pharmacists should regularly visit the operating rooms to ensure drug use, safe drug use, and packaging and formulation changes should be brought to the attention of anesthesiologists before drugs are provided to the operating room. So these are some of the recommendations that have come by, and here they are in more detail for people who want to print this out. Another concern is bad design, such as in this teapot. You can see that that is simply bad design. That can be related to drug label problems, workspace layout, anesthesia machine design flaws. And I want to also talk about some of the patient-controlled anesthesia machines that have killed patients. Technological issues can affect the cognitive load to the patient, where they're spending all their time figuring out what's going on with the machinery rather than looking at the patient. The number of failure modes may increase as technology gets more complex, and there's frustration for the patient and for the clinician, especially for the clinician. This also may result in a focus away from the patient, a risk of fixation error, where you're taking a look at how to get the equipment to work rather than keeping an eye on the patient. Let's take a look at drug label problems. Here, there's recommendations for making sure that if a drug is present in a bag of saline for dilution, that it be put in a standard way that's obvious to everybody. So some people recommend that we have these paper labels in addition to labeling on the ampules and vials, such as shown here, with the barcode that you can scan. So the idea is that in some places you'd scan the drug and then scan the patient, and they would make sure that it's an appropriate match. Workspace layout. Here is a layout that one of the anesthesia residents had for his case, for a complex case. You can see the arterial line and central line transducers on the right, and everything is set up and labeled. I was very impressed with this, and I asked if it was okay if I took a picture of this and give him international credit. So there he is, very happy, working at Cleveland Clinic in a complex case that he had very, very well organized. Another problem is potential anesthesia design flaws. And here's an article I wrote, Special Challenges with New Digital Anesthesia Machines. And this is 20 some years old that I wrote. And here is an example. I'll read it in more details. Some digital anesthesia machines use virtual instead of real gas flow meters. So instead of real gas flow meters that can be seen and controlled, the unit uses simulated flow meters. However, some clinicians are concerned that virtual flow meters may not have the impact of real flow meters in attracting the notice of the anesthesiologist. For example, as noted earlier, some anesthesiologists do not notice that the oxygen flow is set to 0 at the end of a checkout procedure for the Datex Omeda AD unit, which is a virtual flow meter arrangement. So the idea that the flow goes to 0 at the end, it's used to save anesthesia oxygen, but in fact, it can be a problem when you're starting up the case and you don't recognize that there's no flow. So the default in many places now is to start off with a flow of, for example, of 6 liters. Here is a comment that was in response to my commentary. This came from British Columbia, Canada. He writes, Dr. Doyle is absolutely correct in observing the challenges of the new computerized anesthesia workstation. We have similar, though different, observations and complaints about our anesthesia delivery unit. And he goes on to say about the problem of updates and fixes can be very expensive, and they should actually be part of the overall package. I wrote that it is apparent that not all manufacturers committed to careful ergonomic or human factors evaluation of their products. The ideal anesthesia machine to be intuitive and error tolerant. It should also contribute to improved situational awareness. At the moment, such systems are largely lacking. Here's an example of a connector for the pulse oximeter. It can be inadvertently connected upside down so the pulse oximeter doesn't work. A letter in this was published in the Canadian Journal of Anesthesia. So this is from Dr. Oyston, one of my colleagues, and he said, does the probe go this way in the top or this way in the bottom? And it turns out the second way is incorrect and the first way is correct. And here, another design flaw. Here, Aspire ventilator terminates automatic ventilation as a result of sustained airway pressure within the ventilating system. And that can be potentially a problem, as this description here in Anesthesia and Analgesia describes. So one of the things you want to do is make sure that the anesthesia machines are updated from time to time with revised software and other situations, so that we have the best possible product. Now, the final thing I want to talk about is a patient-controlled analgesia machine, which killed a number of patients. The idea here is that you would have a loading dose, for example, of morphine, for example, 4 to 6 milligrams loading dose, and then every few minutes you would be eligible to have the patient push a button to give themselves an incremental dose, such as, for example, 1 milligram of morphine. So a number of problems with these patient-controlled analgesia machines have been identified in the medical literature. Excessive sedation and respiratory depression with PCA often lowers patients' oxygen levels, unacceptable. And in many places, they mandate that it be used with pulse oximetry and other forms of respiratory monitoring. Many of these problems can be due to programming errors resulting from a hostile interface, and some of these problems have resulted in human fatalities. So, although the human patient interface is very simple, it still can confuse some patients. Some patients confuse the PCA button with a nursing call button and give themselves an inadvertent extra dose of morphine when they actually intend to ask the nurse for help getting out of bed. Most designs do not provide with an indicator of the patient's lockout status. A red-green LED light-emitting diode would suffice. Patients can then find out whether their demands are being ignored during a lockout period. Some patients just give up, finding the technology to be unsatisfactory. The value of patient feedback in this setting cannot be overemphasized, particularly letting them know if they're eligible for another dose. Here's a patient who wrote to me after I had written articles on this. I thought you'd be interested in my pain pump experience I had at Tallahassee Memorial. I used to add that any hospital could have been at fault. During my pre-op, no explanation was given what the pain pump was. I went into surgery for removing my uterus and ovaries, recovered, returned to my room, all pain-free. Gradually, the morphine wore off and my pain was real indeed, but the effects of the anesthetic had not worn off and I was quite muddle-headed. The just push the button for pain relief made no sense to me and I could not properly be assimilated by my muddled brain. For well over 5 hours, I suffered while my husband stood by helpless in his efforts to get the hospital to give me something IM or IV other than the push point choice. He wasn't allowed to punch that button for me. Please let anyone know that clear instructions about pain pumps and the frequency that they can be administered ought to be given to the patient in their pre-op appointment, as well as on the gurney awaiting actual surgery. And additionally, a lighted monitor, 4-inch large letters for niche sighted, please, indicating when the next dose is programmed to be available should be mandatory. So these are all good suggestions. And to my surprise, even today, these are not universally available. So, and the next thing to remember is that nurses have to program these machines, and the programming interface can be complex. Nurses must correctly enter the drug concentration, the dose, and lockout period, and other information. And unfortunately, medical instruments frequently have poorly designed user interfaces that promote human errors. And so it is with PCA machines. So here shows some of the potential problems with the Abbott LifeCare PCA Plus. And it shows that how it is loaded up with this special syringe. And what you do is you indicate what the syringe is, but you have to enter it. It does not read any barcode on the syringe itself to know what it is. So Lin and al. Studied the nurse interface for a commercially available product, the Abbott LifeCare 4100, and the interface was then redesigned to allow a dialogue structure with fewer steps, a dialogue overview showing the patient's location. And studies of the new interface showed significantly faster programming times, lower mental workload, and fewer errors compared to the manufacturer's original interface. Human factor studies are obviously needed to ensure safe operation of complex medical equipment, but regrettably, such human factor studies on medical equipment are often abandoned in favor of early market penetration. And in fact, there are a number of drug overdoses associated with the Abbott LifeCare. And the ECRI, the Emergency Care Research Institute, in 1997, documented deaths while patients were connected to this device. Two of these deaths, the alleged mode was that the patient drug concentration was incorrectly entered because of a complex, confusing user interface. So nurses can accept the initially displayed minimum value, for example, 0.1 milligrams per ml, instead of changing it to the correct value, for example, 2 milligrams per ml. And if you do that, the machine will think the drug is less concentrated than it really is. And as a result, it will deliver more liquid and thus more narcotic into the patient and deliver an overdose. And this is what happened in a number of the deaths associated with the Abbott LifeCare 4100. So the Institute for Safe Medical Practice recommended against purchasing Abbott's PCA machine, and any of the lawsuits associated with that were quietly settled. Now, I want to close by letting you know that there are a variety of useful resources for human error. Here are some of the original articles: Human Error in Medicine from 1994, and Error in Medicine from the Journal of the American Medical Association in 1994. And this indicates the beginning of a lot of interest in the human error movement. But now we have a variety of journals. This journal, for example, the Journal of Patient Safety and Quality Improvement, and on the right, Patient Safety, a Human Factors Approach book. There are other books available as well. For example, this one, second edition, Avoiding Common Errors in the Emergency Department, and on the right, Avoiding Common Anesthesia Errors. So these are books that are readily available. As well, I point out that the Anesthesia Patient Safety Foundation offers a lot of very useful stuff. For example, here is an article, letter to the editor, Accidental Intrathecal Administration of Tranexamic Acid During Cesarean Section. Hard to imagine that that could be given, but it was lookalike ampules for tranexamic acid and bupivacaine. So you may want to read that. Remember that articles from the Anesthesia Patient Safety Foundation are free to download. It's a free newsletter. One of the things that comes up is, how should we punish the doctors and nurses that make drug errors? Should we put them in jail? Well, here is the official position, the position statement on criminalization of medical error and call for action to prevent patient harm from error. They write, we believe the prosecution and conviction of the nurse, this was in a drug error that killed a patient, conviction of a nurse involved was counterproductive in pursuit of prevention to harm to future patients and healthcare professionals. They also come up with some ideas that might be useful. For example, here they show how to take the midazolam medication label and remove it from the vial and apply it to the syringe to draw up. And this is the kind of thing that we would encourage all manufacturers to do that can be very useful. So here you can see the label is on the midazolam and you can transfer it over onto the syringe. They also come up with consensus statements. Here's consensus statement, recommendations for improving medication safety in the operating room in terms of standardization, use of technology, pre-filled syringes, and the use of a just culture for reporting errors and a culture of safety. One of the things you'll find also interesting in the Anesthesia Patient Safety Foundation is that they offer debates about various topics. For example, monitored anesthesia care, conscious sedation versus general anesthesia with an intubation for ERCP, and endoscopic retrograde cholangiopancreatography. In many places, they intubate patients for ERCP because of their semi-prone position. In other cases, the proceduralists are so fast that it generally can be done under conscious sedation or monitored anesthesia care. So they offer a pro-con debate summary for this, pro on the left, con on the right. They offer advantages and disadvantages for each of these that can be used for teaching, and they offer risk factors for sedation adverse reactions during monitored anesthetic care. So this is the kind of article that can be very useful from the Anesthesia Patient Safety Foundation. And I'd like to close with a cautionary tale, and that there was a doctor, a cardiac surgeon, immunologist, who took on the role of public advocate for improved oversight in the medical device industry. And he got a job as medical director and patient safety monitor for a company, Becton Dickinson, and he spoke up about the things that could be made better. He started with that company in February, and nearly 5 years after his wife's death from cancer spread by a device using during her gynecologic surgery. But he spoke up and they fired him. So what can happen is that you have to be careful how you speak up, because there are a lot of people out there who are powerful, who can harm you from speaking up. So the hospitals and other agencies have to have a way of protecting people who speak up. So that brings to an end our discussion. And I hope you enjoyed this. And now I will open the floor to questions.
Thank you, Dr. Doyle, for this great, informative, comprehensive presentation. During this presentation, Professor Doyle highlighted the importance of the subject when he mentioned that medical errors are the third leading cause of death in USA after heart diseases and cancer. Then he explained to us that these medical errors could be errors in the diagnosis, treatment, prevention, or errors due to other reasons like technology and equipment failure. Dr. Doyle then presented a few horror stories as examples of medical errors. And he mentioned that during each medical error that harm the patient, there is always another victim other than the patient. This other victim is the healthcare provider who caused this harm to the patients. Then Professor Doyle presented the 6 international patient safety goals, and he highlighted the importance of these patient safety goals and recommended that we have to apply this in our hospitals. And also he highlighted the importance of the operative checklists, which include the sign-in, the time-out, and sign-out process during surgical procedures. And these are very important barriers to prevent wrong patient, wrong procedures, wrong site during surgery. After that, Professor Doyle explained the mechanism or the root cause for the medical errors when he explained the model of the Swiss cheese hypothesis. In this model, there are 4 barriers that protect against the occurrence of medical errors. These are organizational barrier, supervision barrier, preconditions for unsafe act, and unsafe act itself. So when there are some holes in any of these barriers, these holes are the reason behind the occurrence of the medical errors. So the act of medical error is only the top of the iceberg. Behind this act, we have a lot of barriers that we have to fix to prevent the occurrence of the medical error. Then Dr. Doyle spoke about the most common medical errors during anesthesia practice, which includes the medication errors and also errors during the airway management. And he explained the strategies to prevent errors from medications and from airway management. And the last source of medical error, as mentioned by Professor Doyle, was the complexity of the machines that we are using during anesthesia practice, like the anesthesia machine and the patient-controlled analgesia machines. So thank you very much, Professor Doyle, for this very informative presentation. Personally, I would like to take the opportunity of the presence of Professor Doyle today, and I have a few questions for him. I assume that a lot of our audience are from low-income countries, where the budget for the healthcare system is very limited. They cannot afford the technology that prevents medical errors. So what is your advice for our colleagues who are working in low-income countries to prevent medical errors? How they can avoid these medical errors?
So while it is true that barcode readers, for example, may be too expensive for places in people with limited budgets, it is probably not a problem to use educational posters and to follow recommendation timeout procedures, such as recommended by the World Health Organization. So if I would start with one thing, it would be the World Health Organization recommendations, which cost nothing to implement because it's just paper products that you have to follow. You have to change the culture of the institution, but it's not expensive to have protocol sheets that you would follow. And so having recommendation protocols for airway management, for use in the emergency room prior to intubation, in the operating room, these are inexpensive things. It's just a matter of printing out the documents and having people go through them all prior to the induction of anesthesia, surgery and stuff. In addition, when it comes to drugs, we can emphasize in education the importance of double checking and influencing the culture, which is not expensive. It's just a matter of educational opportunities. No technology is really required for that. So that's where I would start.
Yeah, thank you, Professor Doyle. Another question regarding when if the medical error happened already and it caused harm to the patient, how we will deal with this situation after causing harm from the medical error? How the anesthesiologist will deal with this situation? regarding reporting?
Well, there's typically a risk management officer in the hospital, and it would be reported to the risk management officer, who then uses that as an opportunity to identify opportunities for improvement. So there's two aspects to it. The first is, what can we learn from this and how can we improve things? Second thing is, what do we do with the patient and their family? And as a rule, what we want to do is let them know what happened and be honest with them. But you have to be aware of the legal consequences in such a setting, and the law varies nation by nation. And that's why the risk management officer would be the person best able to offer the next steps involved.
Yeah, thank you. Do you think, Professor Doyle, that we have to disclose all medical errors to the patients or his family, even if the medical error didn't cause any harm to the patient, or only in case if the medical error caused harm to the patient?
There's disagreement in the ethics community on exactly this point. We have a saying in America, no harm, no foul. For example, if you gave the wrong drug, but no harm caused, then that's less of a concern than if you gave the wrong drug and harm occurred. One of the things you want to do is document it in the chart and let the risk management officer know. As a rule, if you explain to the patient that you gave the wrong drug and nothing bad happened, the patient's not going to be that upset. Yeah. Where you really have to explain to the patient what's going on is harm happened. And hospitals and ministries of health for various nations will have policies regarding this.
Yeah. Yeah. Thank you very much, Professor Doyle. I couldn't see any more questions in the Q&A box. So